Okay. Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi. Good morning everyone. Today we're gonna have neuro emergency CME class again in this April, in this Ramadan. Thank God, Alhamdulillah, we managed to organize another CME class today. So we're gonna have two topics today. The first one is about pediatric CNS trauma, management and common pitfall. It will be presented by Dr. Abdul Kursi bin Abdul Latif. And the second presentation will be about seizure among pediatric population, what not to miss at ED. We will have this presented by Dr. Ahmad bin Muhammad. So without further ado, I would like to present our first speaker, Dr. Abdul Kursi Abdul Latif. So Dr. Abdul Kursi Abdul Latif is our consultant emergency physician and pediatric emergency medicine fellow in Hospital Raja Permaisuri Bainun Ipoh. He has been practicing as a clinician since 1999 and obtained his fellowship in pediatric emergency medicine since 2015. So without further ado, Dr. Abdul Kursi bin Abdul Latif, the Zoom is yours. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning. First of all, I would like to thank Mr. Chairperson for the kind introduction. A little bit correction. It's not 2015, 2019. I qualified my fellowship in PM. And million congratulations to Dr. Nina as a champion in Neuro SIG. And for this morning, I'm going to share with you on pediatric neurotrauma, or because the Neuro SIG is put as CNS trauma, the management and pitfalls. I'm not going to share something new, but I'm sure in our daily practice, we have encountered children who involved with trauma, but how do we get back it in a proper manner, as a proper approach as well? Okay, ladies and gentlemen, hopefully you'll bear with me for the next couple of minutes. Okay, I got nothing to disclose in this presentation and got no sponsorship. Okay, this is the outline of this morning presentation. I touch on a little bit of introduction. How do we approach in seriously injured child, and a little bit definition of traumatic brain injury, general management, pearls and pitfall in our management, and also summary. Okay, I would like to share with you this young boy, 5-year-old boy, seen in triage. Okay, many years ago. The father noticed child prefer to lie down in supine position past 3 days, and when asking the child, the father said the child said he had headache. That's why he preferred this position. And what's really happening? He claimed that after 3 days prior to the complaint, he played with the brothers. Okay, on the double-decker bed, the head hit the ceiling while jumping. He feel like a little bit, he see some stars, but otherwise he doesn't make a complaint to the parents, and no other significant finding. And in triage, mean patient ambulating well, the pain score about 1 to 2, no other neurological deficit as well. So I think it's quite common you see this type of cases in your practice. Only that in the severely injured cell, probably you will definitely triage in red zone, and this stable enough maybe in the green or in yellow zone. Okay, as for introduction, head injury is a common presentation in pediatric emergency department. So as usual, our data is away from the US. It may lead to acquired disability among the children when they're grown up, and the deficits on neurologic and cognitive are related to patient's age. So if the injury occur during the infancy, so maybe the later they have the deficit, which is maybe delay in developmental and also cognitive function. The time of injury that child sustained, the severity, and also the degree of structural injury, whether it's involved the cerebral or not outside the cerebral. Okay, the challenge is always for us to distinguish the minor head trauma from clinically important traumatic brain injury, which is require maybe neurosurgical review and intervention. And our main goal is to identify which children necessitate radiographic imaging and immediate recognition of clinically indicated traumatic brain injury. Okay, little bit on epidemiology. Neurotrauma is one of the most common reasons for ED evaluation, with more than 800,000 annual visit by children in US. And ED visits for younger children up to 4 years of age have increased significantly. And this one we can see in during the COVID time, BC, before COVID, quite numbers, and after during the COVID time, less number of trauma, but after the PM announcement that there's a rentas negeri, we can see the trauma statistic become increased. And common mechanism of injury are falls, unintentionally struck by or against an object in the nursery, the bigger child struck the younger child, motor vehicle collisions, bicycle accident, sport-related assault, and also non-incidental trauma. And in the foreground, you see, sometimes in the swinging, split off, and then they just fall from the swing. Okay, I would like to share with you on the, I think quite a number of you familiar with this, regarding Pediatric Assessment Triangle, 10-second assessment of ill child. It's not necessarily trauma, but also in medical non-trauma patients. So if you see this triangle, okay, the appearance, the way of breathing and circulation, the appearance, I think you know the mnemonic is TICLS, tickles, the tone, interactiveness, inconsolable crying, and then the look at the eye gaze and the speech if the child already verbalizing. Okay, so if you see this triangle, CNS or metabolic, if the child come to you in triage or even after a while in the observation, okay, something wrong with the appearance, the tone have reduced, child become non-interactive, so something wrong if they have someone with the history of trauma. So probably there's another, it means the CNS issue is quite significant, which need urgent attention. If the child in yellow or in the green, we have to up-triage the child. Okay, as years goes by, from my practice, this is my perspective on how do we manage children with who has sustained with injury, not just head injury. So sometimes we see children who have injury involved in motor vehicle collision, the child stay in the back, they was thrown away. So sometimes we see children was apply some cervical collar which is not appropriate, and then the size, we don't have the size, appropriate size. So sometimes this is quite inappropriate. So what should we do? Actually, if the child, because most of the children, if they are in pain, they will not move. Someone if they have the neck injury or spine injury, they will not move the neck. Then they are still fully conscious. So it's inappropriate for us to put cervical collar on this kind of child. So it's better we put a modified head block. I will show you the picture after this. Unless the patient is fully unconscious, and then definitely from your primary, secondary survey, the child require AV management, or either way is still protected. Yeah, maybe you can put cervical collar because the child already unconscious, because we have to transfer the child to the hospital or for neuroimaging later on. And secondly, no analgesia given or inadequate analgesia. Sometimes I notice we forgot to give them because why the child crying? Okay, I'm sure the event that lead to this trauma or the trauma itself cause significant pain to the child. So we need to give analgesia. For example, suppository paracetamol is easily available, and the dose is 30 mg per kilo for step dose for analgesia. Okay, and the maintenance could be 15 mg per kilo. So it doesn't matter because sometimes our suppository preparation, we got 125 and 250. But most of the government hospital only have 125. So it doesn't matter as long you doesn't reach more than 30 mg per kilo. And not managing the airway in patient post means GCS is low, so we have to manage the airway properly. Again, rather than hectic chin lift, you do jaw thrust or just minimal chin lift to open the airway in the unconscious child. And don't forget to suspect blind abdominal trauma if the history of trauma, because during the fall or during, especially during the maternity, so you have to ask and communicate with the parents. Okay, and further evaluate the child as per ATS protocol, and keep the child warm because most of the ED is very cold. So make sure you cover the child. And what about examining fundus? So this is very important, especially you suspect patient or child have been abused or being beaten up by somebody. And how about CT imaging unnecessary? Because sometimes we do see child, especially empty child, because the father or the parents concerned, and also from the GP. Sometimes the GP doesn't have much info on this, so they say simply refer child with frontal hematoma come to emergency department for CT scan. So they already counsel the parents. So we have to go to ED for CT scan. So sometimes it's dilemma for us. Whether should we proceed or not, because the GP or the KK or the district hospital already counsel the parents. That's why they refer to us. So it's quite challenging for us. So sometimes our MO just follow and proceed with CT scan. And lastly, remember in severely injured child, we have, as a clinician, we have to appreciate whether the child has shock because of the chest injury, abdominal injury, or maybe long bone injury, or even young infant scalp injury itself can cause significant hypovolemic shock. So make sure you assess the child, the circulation, the pulse volume, tachycardia, and appreciate the pediatric appropriate of heart rate of the patient or systolic blood pressure. So remember, we always, I think you're quite familiar how we do practice ourselves, daily practice our trauma life support protocol. IFM has come up with the International Federation of Emergency Medicine. They've come up with a guideline for those country, for those underdeveloped or developing country. Those who developed country, they have their own protocol. Like Australia, UK, they have NHS, Australia, you get RC8, and so on and so forth. So they have recommended, especially those emergency department who have mixed ED. Like in Malaysia, we don't have dedicated pediatric ED except in HKL, which is HTN or Solikas. At the moment, most of ED is mixed ED. We manage peds and adult together. So FM has proposed these are the things that should be all the ER residents should do when they see an ill-injured child. So we have, when the child arrives, even prior the arrival of the child, if the child arrives from the pre-hospital care, maybe you need some information, at least administer, ATM administer. You can Google up what the stand for, administer. Okay, ATMICR for a child prior to the arrival of the child. And all members must be trained and empowered to alert others to the arrival of seriously injured child. I'm sure most of ER residents quite competent and confident managing adult patient, but when they see the child, especially when they are alone, there's only the senior one there. So sometimes the confidence is less there. Okay, the competence is less there because some more child who come to emergency department who are severely injured, not so often we see in our daily practice. Yeah, mild injury quite often we see like all this fall from bicycle, very mild. But the seriously injured rarely we see in our daily practice. Maybe once a month or depends with your center you work for. And the third one is all staff must be highly competent in recognizing the severity and deterioration of the condition. Okay, and the fourth one, sorry, the typo there. An ill-injured child must be moved immediately to resource area and proceed with the further intervention. And next is there must be no barriers to assessing immediate initial assessment by qualified staff member, and all child must receive full initial assessment. So when we do perform primary survey and secondary survey, you have to do it completely. And the choice of efficient model of initial assessment must take into consideration the available staff skill and case mix and current workload. And all child will have a vital sign. What about, let's back to the CNS trauma. The key points are, in older child, they do present it like the scenario that we shared just now, the 5-year-old boy. Actually, the child come when tried to green zone. Actually, the green zone MO have assessed the child with no obvious hematoma of the scalp, but little bit tenderness over the right parietal region. So what they do, because the green zone always a lot number of patients, they requested for skull X-ray. Because very difficult to request CT scan from green zone. In my center, in our center here, if you request CT scan from green zone, you have to communicate. So that's why we put yellow or green if the patient from green zone. Okay, or category. So what happened to this child? Okay, when the skull X-ray was performed, the child, okay, the MO said nothing to the skull X-ray, and then there was this, the child was discharged. Okay, what happened? What happened the next? Luckily, in this hospital, all X-ray will be reviewed by radiologists. So radiologists reviewed the skull X-ray. She said it got fracture on the parietal region lah. Okay, call the child. Inform the MO, call the child. So what happened? We call back the child. The child come back to the hospital completely successful, no pain at all. So since there's a skull fracture, the tenderness still there, no depression. Okay, just a slight tenderness over the right parietal area, no bogginess at all because already 5 or 6 days already post injury. So we consulted neurosurgery. They said you need to proceed with CT scan, even though the child is fully active after about 5 or 6 days post trauma. So what happened when we proceed with CT scan? definitely we need to give some sedation to the child. Okay, what happened? There is some very thin extradural underneath the fracture, but or even the 6-day neuro still admit the child for 20 hours for observation lah. It's quite challenging for us, right? Okay, so this was most injuries are minor and no further clinical intervention. Infants with intracranial injuries may appear to be asymptomatic due to limitation in their neurologic examination. And the most common cause of mortality from child abuse is head trauma, and spinal injury is very rare. Yeah. Then we go to definition to clinically indicate traumatic brain injury. Traumatic brain injury, and we see the child have present or depressed skull fracture like ping pong, especially the younger child, which we discussed is very soft, or young infant especially, which require neurosurgical intervention by elevating the skull, and neurosurgical intervention including invasive ICP monitoring, revision insertion, evacuation of the hematoma of the intracerebral bleeding, for example, subdural, and decomposed craniotomy. And also is include endotracheal intubation for more than 24 hours. So I think this definition clinically more to neurosurgical clinic, because they will manage patient after the subsequently in their follow up. Okay, as per this slide to share with you regarding the definition, definition by the different tools that we know of. We have heard CAN, we have heard about Chalice, Sketch, and XS2. So they have various definition. So I think the definition as per us is not so much important as long we manage as per ATLS when the child present to us, especially the very severely injured child. Okay, there's always a spectrum in traumatic brain injury. It's ranged from minor head injury, like the first case that we have, and most of the child come to us in immediately after injury or head injury, they are very mild. Okay, and like for example, frontal hematoma, they're very active, and so have some concussion, especially the school children. They very active at school. Skull fracture, pneumocephalus, intracranial hematoma, cerebral edema. I think not much different from adult. And what are the unique consideration in children? Okay, because of the expertise nowadays, we have the neurosurgeon, fetal-maternal specialist. Sometimes we do see fetus in the womb, and then they do the ONG clinic, do the detailed scan. They found something while they see the child have hydrocephalus antenatal. So the woman prenatally, the child already been referred to neurosurgery, right? So when they delivered, they took the child and do the CT scan, for example, and proceed with BP shunt insertion at the very young age. So this child are very well now. They grown well and going to school and so on and so forth and develop very well. So sometimes we do see this child, so we have to be careful also. And please ask sometimes when the shunt is there, it's very easy for us to assess. And also a child with underlying bleeding diastasis or platelet disorders, as example hemophilia. This what happened to one hospital. Senior doctor, because the child has intracranial hemorrhage without no history of fall significantly, but the senior doctor suspected NAI. The senior doctors asking the parents, have you hit the child? The parents strongly refused, but because of the senior doctor said probably something happened of NAI, so the senior doctor have made a police report. So the parent was not so happy, but the child have some child disorders. So sometimes we because our aggressiveness cause harm or cause disharmony with the parents or with us and the parents. So sometimes we have to be careful this unique consideration in children, because especially in infants, they are very non-specific. The symptom may be overfeeding, vomiting, irritability, and then if the anterior doesn't close yet, you can assess the bulging anterior fontanelle. And GCS, appreciate the pediatric GCS, and the child appear lethargic. Seizure is one of the features, especially NAI, especially. I've seen a few cases, NAI come to with seizures. Presence of skull hematoma and or depression of the skull. For infant GCS assessment, this slide to show you how AVPU scale correlate with GCS. Right, if the infant is full with is alert, GCS is 15. if the from the verbal scale of ABPU, okay, the GCS definitely not 15. It could be 12, yeah. Okay, 12 and below. If the infant only response was pain, so GCS probably around 9 or 8 or like that. And responsive GCS 8 and below. Or even 3. Okay, all right. So then let's go to clinical pulse in blind head trauma. It may have limited neurologic findings and appear asymptomatic. Clinical assessment often may be challenging, and we have to have a low index. Instead, index of suspicion always should be low. So this one very challenging also. Sometimes in our side, if you couldn't find this, maybe we after the child admitted, we pass over to our colleague from PITS team or from the whatever surgery or auto. They have to suspect them to get detailed history in the ward. And also concussion and skull fracture, what are the clinical pulse and pitfall in concussion and skull fracture? In concussion, the common features involve somatic symptoms. They can have some headache, some non-specific symptoms of the somatic physical sign. You see the maybe abnormality of the behavior and emotional changes within few days of the trauma, and cognitive impairments, and also or sleep disturbance. And normally these symptoms, non-specific symptoms will resolve within 7 to 10 days, right? So that's just maybe from the history, child fall after somebody hit the head or hit the head with using the helmet during gang fight. Okay, so the symptom we treat is symptomatic and reassuring. And goal therapy is physical and cognitive rest. On the skull fracture, most commonly linear parietal denominator skull fracture, like the case that we shared just now on the 6-year-old boy. Skull fractures are common in trauma, MBC, or non-accessory trauma. And this most linear non-displaced skull fracture will heal without any complications. Then this the always issue that we face in our daily practice, when not to CT, right? Okay, this I think you quite familiar. You all of us quite familiar with pecan, because pecan number the samples what 50 they involve what 57 respondents, but only about 52 samples they got together, and it's quite sensitive for clinically indicated traumatic brain injury. They divided into 2 children less than 2 years old and children more than 2 years old. And for the child less than 2 years old who have a normal mental status with normal behavior, lack of scalp hematoma. So scalp hematoma probably from the temporal, from the occipital, and the parietal no scalp hematoma appreciated during your assessment. And if the frontal scalp hematoma without evidence of scalp fracture, okay, in this 2 years old and normal examination, so probably you can escape CT scan. Okay, then for the children more than 2 years old, who the child looks very active, conversing from your PAT assessment, no obvious, again the triangle involve the appearance, means you can exclude there's no loss of consciousness, no vomiting, no severe headache, and you palpate the skull, no evidence of skull fracture, and examination is normal, so you can exclude this. But this back to your setting, or you have observation ward, or you have the appropriate area to observe the child. You can observe the child 4 to 6 hours. Okay, if you see, what you see this image in the photo, this is actually this you can see this is 1, 2. There's another boy. It's a triplet involved in motor vehicle accident. All of them staying at the back because the father micro sleep. The father want to send the elder child to the school, so they have to bring back because the father work as a pasar malam, and about 2 a.m. So they have to bring the child. So one of the child went intubated and went to CT scan. This remaining 2 is not intubated. The first intubated child already they got some extradural and subdural, and now all of the child is. And you notice here we didn't put any cervical collar. We just put there as a modified head block. You use a normal saline bottle and cover your linen, and what you put there is because this child or these 2 child are fully alert and conscious. They are very cute child. They didn't cry. Initially they are crying lah. Okay, we see we plaster the forehead and plaster the chin, so that is quite stable. See, if the child have, because the mechanism is quite significant, we have to protect the child and cover the child from getting hypothermia. Okay, the child actually well after observation in the PICU HDU. All right. Okay, there's always controversy over CT scan for minor blunt head trauma. Okay, study has shown Naden Kupumut, I think the Sifu in Pekan, you can browse the log when LCH has called him to give the talk in December 2016. Okay, okay, even Medca also, Naden Kupumut, Dr. Naden has he put his stool, Pekan tool in the main MD cup. Okay, the study found that fewer than 10% have TBI among large numbers of CT from mean traumatic brain injury significantly cause bleeding. Okay, the drawbacks are, yeah, when we request CT scan for a child, we need to transport child of ED. So who's going to transport the child? Okay, and we need to sedate the child. Okay, for sure the child will cry or very difficult to sedate child also. And what about the cost? So in the developed countries, so most of the cost will be bear by the family or the insurance company. So like for us, one negate got everything. So we have to really consider about this. Most importantly, risk is malignancy, but it's still theoretical because used way back from the World War II, because the explosion caused radiation. Okay, the risk from single city maybe SIS 1 in 2,500 child. Okay, and it's still theoretical. Say for child less than 5-year-old, the risk of pregnancy 2,500, whereas a child for 10 years old, and you expose to CT scan, the risk is 1 per 5,000 to develop malignancy in their later life. And also the risk important from the public health review. So in US also, you see, they also use CT scan unnecessarily probably, but that's why they did this study by Dr. Naden and the group. Okay, you can see it in MD Calc by Dr. Naden. Okay, you see the first statement here mentioned predicts this instruction. Note this only applies to children with GCS scores of 14 or greater. I mean, most of the child who come very alert, post-fall frontal hematoma or minimal hematoma or some bruises over the cheek. Okay, but when it goes to mechanical injury, you feel like, well, maybe require for CT scan or the parental concern. The child had vomiting or the child appear little bit different from usual. So there's indication for observation of CT scan. But CT scan, okay, I think you're quite familiar with this pathway. Okay, not all. So I like to share this one. I think you are also quite familiar regarding the observation of a child. And the additional for less than 2 years old is if less age, the threshold for CT scan may be low for the child who less than 3 months old. In my aspect, I did encounter day 40 of life child fall from the couch. Within 2 seconds, the father turned away, the child already on the floor, and there's a hematoma. We did scan the extradural, but the child we just observed by neurosurgical team, no intervention. So it's up to the clinician who manage the child. Okay, the PCAL is quite good for us to be used in our daily practice. And remember, points to keep in mind, although the largest trial of its kind, the PCAL study had low rates of TBI on head CT about 5.2%, even low rates for CI TBI about 1%. And this suggests overall TBI in children is rare. And head CTs were obtained in approximately 35% of patients, lower than the average estimate of 50%. Okay, which child has diagnosis challenge? Okay, the in between the low or mild head injury to severe head injury, so intermediate one. Okay. Okay, this is a challenge for us. In children with possible isolated features indicative of CI/TBI with dissolution or improvement of symptoms and normal neurologic examination. Mean the father or the parents said that initially at home when they took the child, something wrong, when they come reach ED, we see the child is okay, active. So what should we do? I think that's why observation, we have the role of observation. Okay, active observation, not just leave the child without any observation. And the best thing is the same person, but we work shift, sometimes the observation beyond the shift work. So please pass over properly to your next colleagues who work after your shift. Okay, what are for your children, this is the sign and symptoms. Yeah, I think I'm not going to read this in detail. You can go to post-traumatic seizure. Okay. Yeah. Post-traumatic surgery for us is quite significant. When post fall, I've seen in my eyes, a child, adolescent actually, riding a motorbike, fall, not really thrown away. The involved motivation, the motorbike hit a car at the junction, and then he fall from the bike. He developed seizures immediately in front of me. Seizures, and he stopped. It very brief GTC, and referred to hospitals. CT scan was normal. Neurosurgery discharged the patient. Okay. That way, I think this happened about 5 years back, where the indication for phenytoin is not in the picture yet. Okay. I think I'm going to finish the slide soon. Okay, and then let's discuss further on surgery prophylaxis. Past few, I think since last year, I noticed neurosurgery started to give IV prophylaxis phenytoin in child or adult with neurotrauma. So I found, actually about 10% of post-traumatic seizures among the traumatic brain injuries, especially children with GCS and less than 8, age less than 2, and non-acute trauma will benefit from prophylaxis phenytoin. And now they even give levetiracetam, okay, especially for adult. Pediatric probably they give phenytoin, okay. In neurosurgery, in our setting, I noticed they give levetiracetam for adult patient who has a severe traumatic brain injury as a prophylaxis for PTS. What about hypoosmolar therapy? Mannitol and hypotonic saline as adjunct to decrease ICP. In the pediatric guideline for traumatic brain injury, there's a little evidence to support, but adult study is established. But from the adult study, the PIDS group have used actually hypotonic saline for severe traumatic brain injury in children. They give 5 mils per kilo of hypotonic saline for about 10 to 30 minutes. And I heard that in certain center, neurosurgeon do give for this patient in Malaysia as well. But I got no experience to give such in our chapter. Probably you got experience, so maybe you can share with me share the audience, the participant in your chat group after this. We also have to consider the non-pharmacological therapies to reduce the ICP. Or during the first impact, they have a primary head injury and secondary head injury. So these are the approach of this the institution of non-pharmacological therapy actually to prevent secondary head damage. Like position the head 30 degree. Don't flex the neck, but you have to use the tilt the bed, your couch 30 degree, and loosen the. That's why you don't put your cervical collar as well. So this one will impede the venous return. Okay, that's why it's better put on head block. And what about targeted temperature regulation? Okay, hypothermia post severe TBI is associated with increased mobility and mortality. There's a study in the US, Cool Kids study, which is RCT, is ended early, setting futility regarding the targeted temperature regulation. I will show you after this. The therapeutic hypothermia increase risk in mortality and 10% increase poor neurologic outcome. And actually been suggested by the pediatric severe traumatic brain injury guideline, temperature maintained between 35 to 37. Okay, this is the study I mentioned earlier. The study has been terminated because of they found out you see the interpretation here. Hypothermia for 40 hours with slow rewarming does not reduce mortality or improve global function outcome after pediatric severe traumatic brain injury. Our friends down south from Singapore. Okay, you see Dr. Jean and friend Dr. Jean, our good friend also in our clinical ultrasound. Okay, they did a paper, and when the child have come to their setting, I think also applicable to us also. I think, is it really cause headache for us at working in emergency department? Yes, I think it's like my headache lah. When you see child with a traumatic brain injury or CNS trauma, you see this hematoma, does the patient require CT or not CT? So as long as we follow the protocol as per APLS or ATLS or TLS, I think you will do quite optimal therapy or observation management of our injured child. Okay. Before I end the session, I got another sharing experience. There's a, I think 2 or 3 years old boy was very active, climbing the stairs. Suddenly the child fall from the side, I think about 1 meter height, and the forehead hit the edge of the stairs, and he gets penetrating skull injury over the frontal area. The child was brought by ambulance team to ED. The GCS was full, his opening eyes, looking what are we doing on him, and we see there's a whitish material come out the frontal area. So when we press it, you can feel the frontal bone compressed fracture. It's very soft, right? Otherwise, the officers was very full. So we need to do the scan, and what we do, A, B, C, D, E, we immobilize the neck by using immobilized modified head block, putting on the both side of the neck, and also the plaster the head and the chin, so to keep immobilize the neck. And we intubate the child and we send for the CT scan. And actually the neurosurgeon just repair and cover do the craniotomy, repair the dura, stitch the dura, and alhamdulillah the child was well discharged. I think about 1 week in, after 1 week in ICU. Within hours, I think 2 days in ICU, then later transferred to general ward, the child was discharged. Well, moving over, I'm not sure what the mental function now or during the time, because we cannot really assess. That's why neurosurgery will continue follow up. So never lose hope. When you see children, we always have a protocol as per our teaching. So this is, I think, the last slide for us for this morning session. So in summary, as for us in ER in mixed ED, in suspected or management of clinically indicated traumatic brain injury, we have to really consider a way, intubate the child using RSI, what you're familiar with your own setting, and elevate the midline head position using by tilting your bed, and maintenance of normal oxygen and CO2 parameters, reduces volume resuscitation and prevention of hypotension, because remember, they may have some other injury, chest injury, blood injury, or pelvic injury, or long bone injury, or in the young infant, the scar hematoma. Okay, you have to careful assess the circulation. If the child in shock, you may need to provide fluid resuscitation. And rapid imaging to identify surgically managed lesion and refer neurosurgery as soon as possible. And normal temperature maintenance and adequate sedation. And please prevent hypothermia in child in our ED. I think that's all for this morning discussion. Thank you for your attention. Back to the chairperson.
Okay, thank you, Abdul Kursi. Very interesting, very nice presentation. So open to the other. You have any questions regarding the topics that have been presented?
Fala, I think there is question inside the chat box.
So Dr. Kursi, we have a question here.
Okay, I can read it. All right. Okay, so that we got another 20 minutes. Yeah. Okay, good questions. Thank you for the questions. Okay, first, what analgesic can be used as second line in pediatric group after paracetamol? Okay, what do we have? We go opioid, which is fentanyl, morphine, and also ketamine. Ketamine also good for the sedation. So this one, your setting, if for severely traumatic brain injury, sometimes the neurosurgeon doesn't like the midazolam, but we do have, when the neurosurgeon want to assess, they ask us to stop the midazolam for the sedation. But for the analgesic, the opioid is there, fentanyl, fentanyl. But the good is paracetamol because it doesn't affect the CNS. Okay. Secondly, how to explain the worst persistent vomiting, worst fall in pediatric group. However, it was not significant fall. While playing, standing position, low bed height, etc., syndrome is normal almost all the time. Yes, agree with you. And I think most of the Only that it's challenging for us to determine, because when we're dealing with the parents, parents very concerned. That's why rule for observation after you exclude, there's no obvious from the rule being discussed earlier. Okay, probably you can observe the child for another 4 to 6 hours. The vomiting, so sometimes I check the throat lah, any possible pharyngitis or infection to the throat, or ask the parents what the child took, or ask the caretaker what the child took, what the child eat prior to the vomiting. Okay, something. Is it related to the food or something the child has eat, or is it because the ongoing infection? Maybe you have to exclude any, maybe cystitis infection, or the normal investigation, or have to get the detailed history from the parents or the caretaker. Okay, unless the vomiting is very significant cause the dehydration, you have to treat the dehydration. So I think it's quite challenging. So at the end, you need a consensus discussion with your senior doctors in your setting, apart using the Pekan rule to help you determining the management whether you want to proceed to CT or not to CT. And how do we justify with neurosurgery team for not doing CT in a child as the child looks well? Only complaint was vomiting. Pekan advanced observation. However, neurosurgery put blank rule CT for all referral. Yeah, I think we have to discuss the head of service on neurosurgery. So yeah, different surgeon, different. Yeah, that, or you also communicate with the HOD of the neurosurgery. Okay, can you admit first? But as usual, I think no imaging, no referral. I think also goes to our colleague from Auto. So yeah, if you I think this one is a quite tough question. You are the best person to decide in your setting. Even like the first case, I said I saw the child that 5-year-old boy with skull fracture after day 5 of post-trauma. Even though the skull is still got fracture, reported by the radiologist. I said, no need lah, no pain. I asked the father, what happened? What? How the child? Bapak cakap, the child more active now, doctor. Lebih suka main active. So, but the neurosurgeon still want CT scan because the fracture there, man. Lucky enough, when they do CT scan, there's a healing extradural, small extradural, but they still admit the child, but nothing, no surgical intervention. Oh, but you see, radiation have been exposed to the child. Yeah, hopefully nothing happen to the child next 5 or 10 years, hopefully, inshallah. So this is quite tough changes. Maybe in the future we have a very good consensus among the team, among the specialists, we have Malaysian consensus on CT scan for children probably. So we'll have Dr. Ahmad maybe. All right, any other decision? All right, any other question? Hopefully my answer is from maybe the expert. Maybe if there's another better answer, maybe we can offer to you. Better one.
Dr. Kursi, Nasrina here.
Yes.
I have 2 questions actually. I start off with the first one. Actually, I have this one unsettling thing inside of me that what is the best fluid for a younger child to be started off when we are suspecting or has been diagnosed with traumatic brain injury? Because normally we'll put patient on a half saline D5 or quarter saline D10. But we know that in traumatic brain injury, we would like to avoid giving patients with hypotonic solutions. So can you comment on that? Because there are also some opinions saying that hypoglycemia will be more detrimental for the child if we do not supply some glucose for the child, especially younger infants like infants or toddlers. So nak tanya, what do you think about it?
Yeah, thank you for the excellent question, Dr. The champion neuro SIG. So how do you settle that?
It's difficult. I think I've asked one of the neurosurgeon. They said because the sodium in the fluid that's being given to the patient is appropriate for the age. So we do not want to have hypoglycemia, which will eventually affect the patient TBI outcome. So we just follow the recommendation from the neurosurgeon.
Yeah. There's always some opinion from the managing team because the primary team is neurosurgery. Okay, with the PIT side maybe have different opinion because some, especially PIT intensivists, some depend which center they are trained for as for PIT intensivist. So I think we would like, I think as for us, we entertain the request by the managing team because at the end we only involve the initial management of the child. it's not wrong to start with one predefined normal sign as a usual maintenance for the child, because yes, as you mentioned earlier, child tend to have hypoglycemia. So yeah, I think the best, always communicate with our friends from there. So yeah, I think that's the even from your response just now is, I think, as a learning curve for us also, lesson learned for us also actually. Yeah, work as a team, and I'm sure in ICU they have even maybe, that's why they have to see child as a whole. Okay, for neurosurgeon maybe they look at the brain itself, and for us, for the remaining team, you have to see the child as a whole. May I go to the next question? Dr. Hamim from Labuan.
One asking about any role of tranexamic acid for TBI in a pediatric population.
Okay, if you see the PECAN not just concerning on traumatic brain injury, there are multiple studies. Okay, they also actually is advocated to give IV tranexamic acid in child with severely injured child. Severely injured child, okay, not just head injury, chest injury, abdominal injury, or torso injury, or pelvic injury. Okay, it's good. Even in the APS 2016 or 6th edition, they advocate. You see severely injured child. In the first box of the algorithm is mentioned to give IV tranexamic acid 50 milligram per kilo. So I guess it's also they extrapolate from the crash restart trial. Yeah. Okay, that's why they advocate. Even the APLS guideline, they advocate to give IV tranexamic acid. The first, when the child arrives to your center, okay, after the A, B, C, and then you can start give your IV tranexamic acid. Yes.
Oh yeah, from Nina again. Why frontal hematoma is excluded from the criteria for CT scan consideration in a less than 2 years old? Is it because the likelihood of meningeal artery?
Yeah, I try to go also what the exact answer, possible because of that. And if you see, even I would practice also, when you see the child with frontal hematoma, most of the child is very active, and then it's proven by the PECAN findings. Yeah, okay, this child unless the child, because the maternal concern, the child become less active, less feeding, I will still observe the child first. And sometimes I mengalah juga because the GP have give some misunderstood explanation, misunderstood the parent. So I'm not sure the exact reason why the frontal hematoma really not indicated. But you see, if less than 3 months old, the frontal hematoma, yes, you still may consider for CT scan because the skull is very soft still. If you see the less than 2 years old pathway just now.
Any other questions from the floor? Okay, Dr. Chris, I have a question. 4 to 6 hours observation, is it a magic number, or is it standard, or is it
because most of the guidelines mentioned that even if you have observation ward, even observation, because within these 4-6 hours, what's the policy of your observation ward? Normally about 6 or 8 hours prior the observation. Okay, you have to need. I don't have the exact reason why, but most of the recommendation said you have to observe that. Even the dehydrated child, any child presented to you, to your ED, dehydration or mild AGE, you may observe the child for 2, 4, 6 hours, right? So I think I don't have exact answer for that. Sorry for that. It's not like magic in medicine. It's not like mathematics. It's always an art in medicine in managing patient. So the moment with that, that's why this ample within that 4 to 6. Hopefully we can see if the child become which better. No deterioration in clinical function, have come to the normal pre-ED admission. Okay, which is quite safe. But unless and prior this, you have to give adequate education or explanation or reassurance and make sure the parent understand. Sometimes our challenge is the language barrier, especially those who are non-Malay or orang asli. Okay, we have an incident, traumatic brain injury initially, because the communication failure, involve the adolescent. We just treat the concussion, but because the parents maybe not understand the explanation, the child actually got extradural, actually died after 3-4 days after the ED visit. So you have to ask the parent, do you understand? What do you understand from my explanation? to ask the parents back what do they understand about the child injury. Okay, Dr. Anas. Wow. If we have child with injured brain with midline shift and surgery may be delayed, which hypoosmolarity is preferred? Hypotonic saline or monitor or none or all? So otherwise, so again, we need to communicate with our neurosurgeon. I think hypotonic saline is quite safe enough, except with our discussion earlier. You can give hypotonic saline to buy time. By time, 5 minutes per kilo over 30 minutes. And I think at the end you have to discuss with neurosurgery because, yeah, when the woman, actually I think it's good also before they open to minimize the cerebral edema. So it's up to the managing team. We want to choose. Okay.
Yeah, next question we have from Dr. Azma. How many times of vomiting is considered significant? Is it same as adult, 2 or more, or any episode of vomiting is considered significant?
It's also subjective. Yeah, in the mention more than 2, adult. So even sometimes after hours in ED, 2 hours is just become vomiting. So I think yeah, the guideline is that guideline mentioned there more than 2, but at the end you look at the child as a whole to find out what's possible cause of the whole. Is it related to the traumatic brain injury or is it another causes that create the vomiting? That is quite challenging for us to decide. So again, observation, proactive observation, the assessment, and communicate with the parent. If the child behave differently, if this can child tolerate orally, so it's quite, I think, the daily thing that we do in our practice. And guidelines always help us to proceed with the patient management. Or else communicate with our friends from neurosurgery. Sometimes I do refer to they say admit lah for observation, admit in the ward for 24 hours.
Okay, any other questions from the participants? Okey, Dr. Kursi, ni soalan burning lah. CT scan versus observation in mild traumatic injury, you akan berat ke sebelah mana? Sebelah observation or sebelah CT scan?
Mild traumatic brain injury.
Yeah. Or you are strictly following the PICAN?
PICAN is a rule. Because who is the best person to manage the patient at particular time, particular moment? So the managing doctor. Okay, managing doctor. It's good if you the first person who review the child at the arrival and before after hours, you are the one who assess back the child. If the clinically child behave the same, no deterioration of function, the parents also happy that the child is no changes in activity or behavior, or child became feeding well, more actively playing, you give stickers, child interacting with you, so fair enough to discharge patient without any CT scan. But ensure the parent understand what you're talking about, what your explanation. Or else, because sometimes the challenge is a language barrier, especially the different language when you communicate with the patient. Or maybe you can use the other Bangla or Myanmar or Chinese orang asli. You have staff MA orang asli, communicate with the orang asli. So in our experience, orang asli got wrong interpretation. That's why we lost that 17-year-old patient.
Thank you, Abdul Kursi and Abdul Latif, for your time, for the very good presentation today. So,
Fala, I'm gonna stop recording first, then we're gonna start for the next presenter.
Okay, terima kasih semua. Assalamualaikum.
Thank you so much.
Hopefully benefit for you all. Sorry for any inconvenience.